Hello and welcome to this talk about orthopedic upper limb injuries. In this talk we will be talking about upper limb injuries, pathologies, identification of certain pathologies on X-ray, and the treatment of injuries and fractures. Let's work our way down from the top to the bottom of the upper limb. First, we're looking at clavicle injuries. These are often a result of indirect trauma onto the shoulder or the arm. If you compare both sides on this picture, you can see an obvious deformity over the right clavicle. This is clearly reflected in a midshaft fracture of the right clavicle on the X-ray picture. Clavicle fractures are primarily managed conservatively in a broad arm sling. Indications for orthopedic referrals are open fractures, tented skin with risk of perforation, or associated neurovascular injuries. Ensure you have excluded other injuries, and associated pneumothorax should not be missed. Acromioclavicular joint dislocations are usually caused by direct fall onto the shoulder or violent movement of the upper limb. There are several classifications available. The easiest is the TOSI classification. These grades injuries into 3 grades. Grade 1 is no obvious deformity on X-ray. Grade 2 is up to half displacement of the clavicle against the acromion. And grade 3 is complete disruption of the joint with complete separation of the acromioclavicular joint. Another commonly used classification is the Rockwood classification. This classifies 6 types depending on the affected soft tissues, the ligaments, capsule, and muscle attachments. If you look at this picture, you can clearly see an asymmetry between both shoulders. The left shoulder is nice and round. On the right side, you can see a prominent acromion. On palpation, you will find an empty glenoid fossa. You may also find some swelling or bruising. There will be intense pain and an inability to move the shoulder. There may also be neurovascular deficits. Most commonly, dislocations happen anteriorly inferiorly. Occasionally, you will find a posterior or inferior dislocation. Most commonly, dislocations are caused by forced external rotation or abduction. Ideally, 3 images are obtained: an AP, a Y, and an axillary view. Reduction should be attempted as soon as possible. Analgesia and sedation may be required. Here we see 3 shoulder X-rays. The image on the left shows a normal Y view of a shoulder. Y is formed inferiorly by the blade of the scapula, anteriorly by the coracoid process, and posteriorly by the spine of the scapula and the acromion. These 3 join at the level of the glenoid. This is where you would expect the humeral head in a normal shoulder. On the bottom right X-ray, you will see the humeral head posteriorly to the scapula, and therefore a posterior dislocation is indicated. The X-ray above shows a light bulb sign for posterior dislocation. Reduction of dislocated shoulders is a complex topic. For the sake of this talk, we will focus on 3 common procedures. The simplest is the external rotation method. Here you externally rotate the upper limb to 90 degrees. If this is not enough, you may slowly elevate the arm. For Kocher's maneuver, you flex the elbow to 90 degrees and externally rotate the shoulder. You then adduct the upper arm across the chest in external rotation. Following this, you internally rotate the shoulder by placing the hand onto the opposite shoulder. A third method is the modified Milch's method. Here you apply traction to the arm and externally rotate. You then slowly abduct the arm to up to 110 degrees. Whilst abducting the humerus, the humeral head needs to be manipulated back into position. This can be done by an assistant. Post-reduction check X-rays should be obtained. Pulses and sensations need to be checked. A collar and cuff should be applied, and follow-up in fracture clinic should be arranged. Humeral head and neck fractures are injuries of the older osteoporotic patient. They are usually the result of direct trauma or a fall of an outstretched hand. Management is generally conservative in collar and cuff. Elderly patients likely require more assistance with their activities of daily living and may benefit from an OT or PT assessment prior to discharge. In absence of a bony injury, a rotator cuff injury should be considered. These are generally managed with analgesics. Possibly a broad arm sling could be offered. Some patients may benefit from physiotherapy. Only in severe injuries, referral to orthopedics might be considered, where surgical repair could be offered. Let's go to elbow injuries. Elbow fractures are sometimes difficult to identify. There are two lines that help identify abnormalities in the elbow. The anterior humeral line is drawn along the anterior surface of the humerus and should intersect the middle third of the capitellum. It is used to identify subtle supracondylar fractures. The radiocapitellar line is drawn down the neck of the radius and should intersect the capitellum. It is used to identify radial head dislocations. The fat pad or sail sign can be an indicator of an occult fracture. It is the result of a joint effusion lifting up the anterior and posterior fat pad. Supracondylar fractures are commonly caused by a direct fall onto an outstretched arm or a direct blow to the elbow. The Gartland classification describes three different types. Type 1 is undisplaced, Type 2 is displaced with an intact posterior cortex, and Type 3 is displaced without cortical contact. The most commonly affected nerve in association with a supracondylar fracture is the ulnar nerve, followed by the median and the radial nerve. Patients need to be referred to orthopedics if there is a neurovascular compromise or displacement of the fracture. Referral should also be considered for substantial swellings. Displaced fractures should be manipulated in theaters and potentially fixated. Undisplaced fractures can be put in a above elbow back slap and followed up in fracture clinic. Pulled elbows can often be diagnosed by history alone. Typically, the children are younger than 5. An X-ray would display a dislocated radial head. Often the pulled elbow reduces itself. With pain, the child will hold the arm still at the side and refuses to bend or rotate the elbow. Reduction can be achieved by supinating the forearm and flexing the elbow with one hand whilst the other hand's thumb pushes down onto the radial head. You can typically feel the radial head falling back into place. The child should be observed for a short period of time to ensure normal function has been restored. Moving on to wrist fractures. The most common fracture in elderly people is a Colles fracture. It is usually the result of a fall of an outstretched hand. The result is a distal radius fracture. There is usually posterior and radial displacement, resulting in the typical dinner fork deformity. If there is significant shortening or angulation, these should be manipulated in the ED. There may well be ulnar styloid fractures associated with this. You must check for neurovascular deficits distally. To reduce a Colles fracture, you require 3 people. One who does the manipulation, one who applies counter-traction, and the third person to apply the cast. Adequate analgesia needs to be offered. Entonox, Penthrox, with or without hematoma block is advised. If a hematoma block is used, you need to wait 10 minutes before its effectiveness starts. You start the manipulation with disimpaction and move on to flexion and ulnar deviation. A below elbow back slap should then be applied. Check your neurovascular status after the plaster has been applied. A check X-ray should confirm adequate reduction of the fracture. If satisfactory reduction is achieved, referral to the virtual fracture clinic should be arranged. The patient should receive a sling to support his arm. Elderly patients may benefit from an OT or PT assessment prior to discharge. Pause the presentation and have a look at the X-rays. Try and identify the fractures you can see on this image. The left image shows a palmar displacement of the distal fragment of a distal radius fracture. This is typically called a Smith's fracture. On the right, you can see a volar fragment of the distal radius that has slipped anteriorly and proximally. This is called a volar Barton's fracture. Both these fractures are highly unstable. They should not be manipulated and discharged from ED without orthopedic review. Next, we'll be talking about scaphoid fractures. This is typically an injury of a younger adult following a fall onto an outstretched hand. Clinical signs are tenderness over the anatomical snuff box, tenderness over the scaphoid tubercle on the palmar aspect of the hand, and telescoping of the thumb. There will also be pain on flexion and ulnar deviation of the wrist. On suspicion, scaphoid X-rays should be requested. This includes 4 views of the scaphoid in different angles. Even with normal X-rays but high clinical suspicion, a splint to immobilize the thumb should be applied, as there's a high risk of avascular necrosis. A referral to a virtual fracture clinic should be made on discharge. In all patients with distal upper limb injuries, ensure all rings are removed to prevent later complications. Consider offering a sling to help reduce swelling and pain management. Consider X-rays to exclude retained foreign bodies or underlying fractures. Ensure you perform an adequate functional assessment, including neurovascular assessment for each injury, as this may require further investigation, potentially under anesthetic. As unfortunately we won't have the opportunity to raise any questions at this point, please don't hesitate to email them or raise them as soon as you arrive in the department. To summarize, we talked about upper limb injuries, including clavicle fractures, AC joint disruptions, shoulder dislocations, rotator cuff injuries, elbow fractures, the pulled elbow, wrist fractures, including Collis, Smith's, and volar Barton's fracture, scaphoid injuries, and soft tissue injuries. We talked about the common findings on X-rays and the appropriate treatment for the individual injuries. I hope to see you all soon on the shop floor where we can go through all of this in more detail. Thank you.